Okay, welcome to the geriatric lecture. So why do we have a specific module on geriatrics? I think it fits in nicely in the neuropsych section, but it is kind of an oddball one. Not a ton of testable material out of this lecture. We aren't really going to be talking about new drugs, and I'll kind of point you into the directions I want you to remember. There will be some exam questions related to geriatric medicine. And at the end of this lecture, we do talk about dementia. So there is more of a disease state here. But with respect to the stats and things like that, again, nothing really testable other than a couple things that I'll specifically direct you to. All right, so this slide has a lot of statistics on it and talks about the basic concept that we're having more aging population in the United States, and it affects healthcare substantially. So we spend a lot more money towards the end of life for people, and as we get more people living longer, that compounds the problem. So that is the gist of it. And when we talk about, from a pharmacy perspective, how that impacts it, it really comes down to like what impact can we make by optimizing pharmacotherapy in patients. So just like any patient group, geriatric patient need medications for appropriate duration and treatment. However, side effects can be much more pronounced in older adults. So the question, or the thing to remember is that adverse effects have a more pronounced effect in younger populations and older populations usually. So we really want to make sure that we're using the correct dosing and correct intervals when we treat a patient, especially one who's elderly. Here's an example for dose adjustment. So most things you're dose adjusting using creatinine clearance. And for example, you have a 65-year-old woman or an 85-year-old woman with serum creatinine of 1. So both of them have normal functioning kidneys, no kidney disease. They're the same height and weight, but you can see the big difference in creatinine clearance, that how it'll calculate. So the equations out there that calculate how much your kidneys are filtering are heavily based on age. It's a big variable. And so if you have a patient who is on this, these two patients might be, on paper, if you didn't look at their age, they're exactly the same. So if you have one patient who's getting but you might have them on the same drug, yet one person's getting a lower dose because of their age. So we do dose adjust because of age. As you get older, your kidneys start to shut down a little bit gradually, and your liver starts to process less efficiently. No real surprise there. And at the end of the day, you still might have a normal lab value, but it doesn't mean your kidneys are functioning like they did 20 years ago. So that's the way that we look at this. So it's always important when you have elderly patients to look at their creatinine clearance. And I think that's a big thing that I see a lot of the providers I work with in urgent care and ER, that they just prescribe things to an elderly patient like they would a normal healthy adult, because the person, for all intents and purposes, is a normal healthy adult. There's nothing really wrong with them. They might be just in for a UTI or whatever it might be, but they happen to be in their 80s. It is still important to calculate it out, look at the creatinine clearance or GFR or whatever you're using, make sure you're dose adjusting that properly. Other changes: poor GI absorption, increased adipose and less muscle means less changes in distribution. Thinner skin may affect transdermal products. Those are some things to keep in mind. We talked about this last semester during kinetics, but just to reiterate it for our elderly population. Other kinetics, some vitamins don't absorb as well. Distribution, you might see lipid-soluble medications having an increased half-life. Benzodiazepines like diazepam will be much more significantly enhanced. Diazepam has a lot of, we haven't talked about benzos yet, but diazepam has a lot of active metabolites. It's got like 100+ hour half-life. The benzodiazepines that start with LOT, lorazepam, oxazepam, and temazepam, don't really have active metabolites, so they'll be a little bit more consistent. Highly protein-bound drugs will have increased free levels, so phenytoin, warfarin. We'll talk about phenytoin. It's an epileptic drug, but warfarin we've, of course, talked about extensively already. Metabolism. First pass metabolism will be reduced. So something like morphine, for example, might not get metabolized as quickly. So morphine in a younger patient is very predictable in how it affects pain management and its kinetics. In an older patient, we prefer drugs like hydromorphone or fentanyl, actually, because they have much more consistent kinetics and they don't have as many metabolites, and they aren't affected by multiple different pathways in the liver. They pretty much go through a standard pathway. You don't have to worry about their effects in the elderly. So that's why we prefer those, like for post-op pain or for more intense pain, acute pain, we'd prefer an opioid like hydromorphone or fentanyl versus morphine. Excretion. Again, we talked about renal dosing. When in doubt, if you have a patient and you're just at, I shouldn't say just because these are very important places, but if you're at working in a minute clinic or someplace where you just don't have access to lab values, or you don't feel like getting labs on the patient because you don't need to, you can always use their creatinine clearance as 1 and just assume they have healthy kidneys and then plug it into a calculator. If you're like, gosh, this person's 89 and I want to give them Keflex, do I have to renally adjust that? Well, you could call a pharmacist and ask. If you don't have that option, plug it into some kind of a calculator. You should have something like this in an app on your phone, or you should be able to find it online. Or worst case scenario, you memorize the formula and do it by hand. Not that a lot of us do that anymore, but certainly it's something that you could theoretically do, right? But anyway, there's no real excuse for not being able to check a creatinine clearance, and most electronic medical records or whatever system you're using should have the capability to do this. Anyway, the point is plug in 1 or plug in 0.8 even if you want, or something like that. For example, the interesting thing is, like in our to avoid over calculating people's kidney function in our health system, if you're over 65, we automatically round your creatinine clearance to, or your serum creatinine to 1. So if your serum creatinine comes back at 0.5, you could end up calculating really high if you have a high body mass, even if you're older, especially if you're a male. But we actually round you up to 1 just to make sure we're normalizing that a little bit more. That's not a guideline thing. It's just something we do in the hospital. There are some studies that support that. But anyway, that's enough of that. General drug-related problems. Polypharmacy is pretty rampant in the elderly population. Medication overuse is what we call polypharmacy. The definition of it technically is 5 or more medications, which means that basically every person I ever talked to at the hospital has polypharmacy going on. Inappropriate or duplicate prescribing, higher risk for adverse drug reactions, higher risk for drug interactions. This is really where I personally define polypharmacy. I don't think use of 5 or more medications is actually a problem. Yes, it's a lot of medications, but there's a lot of people that need 5 or more medications for different conditions. So certainly if you see somebody, I think it's meant as a benchmark to say, all right, when you see somebody with a med list more than 5, you should question why they're on all their meds. And that's probably a good rule of thumb, but you're going to run into a lot of people that take more than 5 meds. And then if you throw supplements and vitamins and OTC products on there, gosh, you're going to end up with the majority of the people who are adults taking more than 5 medications. And that's just the way it is. So is that really polypharmacy? In my opinion, no, not really, but it's there. So again, it's the inappropriate and duplicate prescribing that I'd really want people to clamp down on. Look through their drugs, look at the classes, look at why they're taking things. Do they have 2 medications for the same indication? That's the red flags you should be looking at. Medication underuse. This is also a really important problem for the elderly. Sometimes people say, well, aspirin's not important if they've, because of the bleeding risk. Well, if you've had a stroke, aspirin is important. Antihypertensive. Some people say, well, we don't want our elderly patients falling over because of orthostatic hypotension. Well, if you don't treat their hypertension, they could have a stroke or an MI. It's really important to make sure that we are treating that appropriately. Antidepressants. Antidepressants are oftentimes maybe even written off in the elderly, saying, oh, people get maybe a little bit down in the final years of their life. But there's actually some really good data that support that low-dose antidepressants can improve quality of life for elderly patients and have very minimal side effects. Thrombolytic agents, so people who have strokes, this is one thing that I think people might not realize coming in or realize right out of school is that, we use thrombolytics in older patients all the time. I've seen thrombolytics in 90-plus-year-old patients used at our hospital. It depends on what that patient's disposition is prior to the stroke. Were they a relatively healthy 90-year-old? Yeah, let's give them TPA and make sure we clear that clot as soon as we can. Give them whatever remaining years of their life are as functional healthy years, right? And then osteoporosis medications, keeping those up through the geriatric years to make sure that the person is at as low risk for a hip fracture or vertebral fractures, things like that, as possible. Anticoagulation is tricky. I think fears of falls may contribute to having people avoid anticoagulation. But you definitely use it if it's appropriate. Non-adherence, intentional versus non-intentional. Sometimes patients might just forget, or they might have some cognitive impairment or memory impairment. early memory loss, things like that. It's important to make sure that the person has some sort of support system set up so that they can either have maybe somebody checking in, making sure they're taking their medications, managing their medications for them, setting up pill boxes or reminders or things like that. All right, let's talk a little bit more about medication use in elderly patients. Just a chart that can show you some of the things that might impair different functional status in our elderly patients. One of the things I want you to remember for an exam purpose, and I'll ask some questions about this, are mental status impairment. I think one of the things I see most commonly is delirium or some sort of altered mental status, and we don't really know exactly what it is. And I think the biggest culprits that are always put out are things that are anticholinergic, so drugs like, and to keep some drugs in the back of your mind that are anticholinergic, so diphenhydramine or Benadryl, really common OTC medication. People might take it for sleep or whatever, very anticholinergic. Muscle relaxants, basically all the muscle relaxants we talked about during the pain lecture, so things like cyclobenzaprine, crisaprotol, they're mostly anticholinergic. Tricyclic antidepressants we haven't talked about yet, but they are anticholinergic as well. And then benzodiazepines have a high link to delirium, especially in the acute use. So benzodiazepines are things like diazepam, anything that ends in zapam. And I know we haven't talked about those specifically, but I would like you to be able to recognize a benzodiazepine on exam. So I'll probably use diazepam just because it's one we've talked about with respect to muscle relaxant and things like that. But just know that benzodiazepines have a big area to cause some acute mental status changes. We'll talk about cholinesterase inhibitors here in a little bit and how that they can improve that. Emotional state, there's some drugs here that aren't real common or kind of niche drugs. Continence, again, anticholinergics show up here again. Another reason not to use them. Alcohol, diuretics, things like that. Alpha blockers can affect the way that the body eliminates urine, so that can be problematic for some elderly patients. Mobility, muscle bone integrity, so glucocorticoids, long-term protein pump inhibitor use, can be problematic, and of course calcium, vitamin D, bisphosphonates can help with that. Balance, dizziness, falls, sedatives, opioids, benzos, sleepers, antihypertensive, tricyclic antidepressants. So opioids would be the other one. So the three that I always think about, well, there's some subcategories in here, but the big three I think about with respect to red flag elderly patient are opioid use, benzodiazepine use, and anticholinergic medications. Now, within anticholinergic medications, we've already talked about there's a number of medications that are anticholinergic. So like muscle relaxants, tricyclic antidepressants are anticholinergics. There's some antipsychotics that are anticholinergic too. The big thing is to know the anticholinergic meds. So we've talked about some of them. We're going to talk about some more in the next module too when we talk about psychiatric medications. Sleeping medications. We'll do a whole lecture on sleep, talk about drugs like Ambien, but those would be big ones too. Okay. We won't talk about extrapyramidal symptoms. That's more of a psychiatric thing. We'll come back to that next module. So don't worry about that right now. All right. So why are medications such an issue? On average, a person between ages 65 and 69 takes 14 prescriptions a year, and 80 to 89 takes 18 prescriptions a year. Now again, are they all appropriate? That's a great question. That's a case by case. You can't make a generalized statement saying, oh, they should be on less medications, because maybe they actually need 14 prescriptions a year. You don't know until you actually dive into somebody's chart and really look at why they're taking certain medications. A lot of adverse drug effects in geriatrics are due to what's called in the industry of safety and geriatric medicine as PIMS, or potentially inappropriate medications, and lead to or contribute to hospitalizations. So the prevalence of adverse drug events in geriatric patients is up to 35%, and up to 30% of geriatric hospital admissions are due to adverse drug events. So where I'm going with this is that if you can reduce drug side effects, you can reduce hospitalizations, and you can save the patient a lot of heartache, and you can save the health system a lot of money too. So that's the big issue around geriatric prescribing and geriatric medicine, and why there's a lot of talk around this. So you might have heard of the Beers criteria. Hopefully this has been brought up at some point, but maybe not. If not, the Beers criteria is a really famous list of medications. And when it first was published in 1991, it basically was just a list saying, here's a bunch of medications, don't use them in the elderly, or use them with caution in the elderly. Since then, it's gotten a lot of different updates and stuff. And by the way, I stole some of these slides from a colleague a while ago, and I've kind of been updating them as time goes on. But the Beers criteria gets updated periodically. And there's some other criterion too, like there's some European guidelines that came out in between the 2003 and the 2012 Beers updates that showed some differences and saying, well, we shouldn't just look at a list of medications. We should look more clinically than that. And so that's been the focus. And we'll talk about that here in a second. This slide's kind of confusing, but basically it shows some differences in between some of these different consensus panels. So in case you wanted to know it, a little bit of the background as to how these studies worked. A lot of them just use expert consensus. They look at different drug criteria to say, all right, should we stop different medications? Should we recommend different medications in different categories? How should we split up the medications? This particular Beers criteria, again, was developed in 1991. This is the most common one cited in the US, I think. It's an explicit criteria listing high-risk medications. The 2015 version is the most recent one. It has over 50 medications or medication classes divided into 3 different categories. And again, the Beers criteria has gotten better over time, but it still really is fundamentally a list of potentially inappropriate medications to watch out for using in the elderly patients. Categories. PIMS and classes to avoid in all older adults, PIMS and classes to avoid in certain diseases and syndromes, and medication to use in caution. So they've split it up. It used to just be one kind of list to say, be careful, avoid, don't use, we don't really know. These are bad medications for elderly, or possibly bad, right? And so now they've stratified it a little bit better. You can go to AmericanGeriatrics.org and look at the Beers list if you want to look at the specifics. And this might be the old 2012 one, but there is a newer one from 2015. So maybe that's available if you do some Googling. If you're wondering how the list and criteria have changed, and just some examples. So for example, some of these things were on here originally. So they said don't use clopidogrel if you're on anticoagulation. They said don't use pseudoephedrine. Don't use oxybutynin or tolterodine. Well, those are medications for urinary incontinence, which primarily affect older patients. So they took that recommendation off. Don't use loratadine. Loratadine's Claritin. I can't think of a more benign medication. I don't understand why that was ever on there. Maybe it's very slightly anticholinergic. I'm not sure, but anyway. So some of this stuff has disappeared with different evidence or different recommendations, and other things have been added. So primary prevention, aspirin, taking it off. So we don't want. And I think this has been pretty widespread. We don't really use aspirin for primary prevention in really anyone anymore because there's not good evidence that taking an aspirin is good prevention for anything. You use aspirin if you have a stroke or have a MI, then you take it to prevent another one from occurring. Antiarrhythmics was added. Some of the benzodiazepines have showed up, like clonazepam. Some of the sleep-like medications, which would be an example, would be Ambien or Zolpidem is a generic of that, which we'll talk about later. They say don't use dabigatran, which is one of the newer anticoagulation medications, right? That's Pradaxa. So I think the theory behind that is that there's no reversal agent, and it's not very well studied in elderly populations. And there's some other things on here too, which are kind of interesting. Prasugrel, which we talked about having a higher bleeding risk than some of the other P2Y12s. Yeah, anyway, there's some other stuff on here that's kind of interesting. You can go look at the whole list online if you're curious. As an example of some alternative method of providing a guideline for prescribing for geriatrics, the stop-start criteria were published in Ireland, and they were a group of criteria that not only recommended stopping certain medications under certain conditions, but also starting things. So saying, hey, this is an elderly patient that's not on a statin. They should be. It was developed, there's some stats here that I don't care if you know what a Delphi process is, but it's basically an expert panel developed it. And they came up with 65 criteria for stopping things and 22 criteria for starting. And unlike the Beers criteria, these criteria are listed solely by physiologic system and not really listed by medication class. So it's a little bit different of a stratification. And the START was the first criteria to evaluate if necessary medications have been omitted. So I like the concept of this better, and the reason I'm putting it on here, even though it's kind of old at this point, is that it's the way medicine should be. You shouldn't just look at somebody's list and say, okay, you're elderly, I should look at what I need to stop, but how do I take care of you as an entire patient? And that's what this is getting at, is a more comprehensive guideline to move towards that direction. So for example, something from STOP, digoxin at long-term dose greater than 125 mics per day with impaired renal function. Long-term neuroleptics for sleep. So using something like a antipsychotic agent for sleep, which is actually really popular. We'll talk about that during psych, but so saying we shouldn't really do that in elderly patients. PPI dosing at full therapeutic for more than 8 weeks. We talked about this. That's again in the STOP criteria. NSAIDs with heart failure. We talked about some of that already in this class. Beta blockers with diabetes and frequent hypoglycemic episodes. So remember, this might be a little bit confusing, as I think I glossed over this and I can't remember when I said that, but when you have a hypoglycemic episode, tachycardia is a common response. So people might be used to feeling tachycardic during a hypoglycemic episode. If they're on a beta blocker, it blocks that response, so they have to look for other cues. So that can be problematic for people that they might not realize they're hypoglycemic. Duplicate drug class prescriptions, of course, would be something that would be standard. Examples from START, warfarin in the presence of atrial fibrillation. So actually recommending you put people on warfarin if they aren't already. Statin therapy with documented history. You can see some of the criteria there. Fiber supplementation, calcium, vitamin D for non-osteoporosis. So some very standard stuff, but sometimes people are hesitant to put elderly patients on anything because they're scared of overprescribing or being accused of polypharmacy, but there are some good reasons to prescribe medications to people, and we shouldn't exclude our elderly patients for no reason. Again, my friend went into a lot more statistics than I care about, but basically, I don't know why I keep this slide in here. I should just skip it. But it was a fairly well-validated study that I think changed the way people were thinking about how we should stratify medication recommendations in the elderly. So versus the Beers criteria, none of the current literature really has a comparison direct study comparing ability of each criteria to detect PIMS that are implicated in avoidable adverse drug events. So they did look at, if you were to look at a group of patients and say, okay, what would the Beers criteria tell you to consider, and what would the start-stop criteria tell you to consider. So they said 151 of 329 adverse drug events were deemed avoidable and likely contributed to hospitalization. STOP detected 94 of these, where the Beers only detected 34. So of course, a big difference there in this particular group of adverse drug events that they saw. So with adverse drug events, sometimes, just to put some background on this, sometimes you just can't avoid them, right? If you give somebody a drug and they have an anaphylactic reaction to it and you didn't have any history on that, you have no way to know that. That just happened. That's a drug event. It's life. It's a problem. We treat it. We move on. It's the ones that we could avoid. So it's like warfarin, for example. What if somebody wasn't being monitored appropriately? That's an avoidable thing. What if somebody could have been reversed earlier or something like that? Those are the questions, that would come up with some of this stuff. All right, 2.76 times more likely to find STOP than Beers. And again, the 2015 Beers recommendations adopted some of the STOP criteria to make up for their discrepancies. Here's some issues detected in case you're curious as to what was commonly found. So is one really better than the other? Beers criteria, again, is really just a general list of medications. It's vetted through experts. It's been utilized for years. It is kind of difficult to use just because, again, it's a list, and basically you're just kind of cross-referencing it. It doesn't take into consideration patient-specific issues, and its focus is mostly primarily in the U.S. START is a different, newer process and approach to managing elderly patients that I think makes a lot more sense than how most people are clinically trained, right? Look at the whole patient, look at everything, as far as from should I stop this or should I start this? Are they missing therapy? Should they have therapy edited? It's really editing their whole med list versus just going through it and deleting things. This is kind of how I look at the two differences, but yeah. Let's talk about a patient example quick. We have a 69-year-old female transferred from an outside hospital for placement of a chest tube for a pneumothorax. She has past medical history of COPD, depression, osteoporosis, and hyperlipidemia. Her home medications are there as listed. So what I'd like you to do, it's not necessarily look up the Beers criteria or anything like that. I don't think you need to. What I'm trying to get at is that a lot of this is more or less common sense once you get used to prescribing and dealing with medication. Certainly you can use these references, but look through this medication list. Don't go to the next slide yet if you want to pause it or something. Try and figure out what looks wrong about this list. Is there something that you'd want to question? Is there something that looks duplicative? Some of this medication we haven't we haven't talked about yet, but look at things like indication. Are they taking things at the same time of the day? Are they taking something that looks like it's for the same condition potentially? So if you need to Google them or something like that, go for it. But take a look at the med list. All right, so if we were to do an analysis on this, which of the medications would flag according to Beers or stop start? All right, alprazolam. One of the things I'd point out immediately is that they're on multiple medications for sleep. So they have a bedtime PRN alprazolam, a bedtime PRN zolpidem, and they take mirtazapine at bedtime. All these medications are taken at bedtime. So the question is, are they all appropriate? Why do they have 2 PRN bedtime medications? That's an immediate red flag. No one should really have 2 PRN medications for sleep. That's an instant risk at having some sort of a compounded drug effect there. What I'd look at also is for anything anticholinergic. So tiotropium is it's anticholinergic, but it's inhaled, right? That's Spiriva. So that might flag initially, and you think, oh, it's anticholinergic, but it's an inhaled anticholinergic. So probably not getting a lot of side effects from that. So I don't really see anything terribly problematic here. Duplication, I see venlafaxine here, which is an antidepressant. I also see mirtazapine, which is another antidepressant. Now, some people just take mirtazapine for sleep, so maybe she's doing that, but she's also on an antidepressant. They can be used together, these two drugs, but it's still something to think about. Like, does she need to be on 2 antidepressants, especially when she has other meds for sleep? Really, there looks like there could be some cleaning up here. Big red flag, Norco or hydrocodone, acetaminophen. PRN, why she's on a PRN medication for pain that's a narcotic. How often is she using it? When's the last time she took it? That's always something to ask somebody if you ever see it pop up on their med list. Sometimes it's left over from a surgery for 2 years ago and it just never got taken off from their electronic medical record. It happens all the time. But you can be the person to actually get rid of it so no one has to ask them that question again. Okay, so Beers would say alprazolam's problematic. They would say Norco is problematic as needed with no indication that you know of. Mirtazapine at bedtime and venlafaxine. I think these fall into the questionable category with the Beers because they are slightly anticholinergic, both of them. Most antidepressants are a little bit anticholinergic. Not a big deal, but again, you'd want to tease out the duplicative nature of these two and figure out what's the difference here. Zolpidem at bedtime. So basically the things I pointed out. Stop criteria has most of the same stuff. They would actually say this has a little star next to it because for atorvastatin, they would say, yeah, that person probably should be on a statin, maybe, but you want to dig into them and say, why are you on that low-dose statin? Do you have some risk factors in history? Certainly could be appropriate, but at the same time, I don't see anything else cardiovascular as far as medications go. So what is her CV history, and why is she on a statin? I would ask that question. Again, could be appropriate, could be not, but it's worth checking out. Mirtazapine and venlafaxine, again, duplicate antidepressants. Why is she on both? Does she need both? And then again, the duplicate PRN sleeper meds. So that'd be the big things here. Again, what I'd want you to know is to be able to recognize some duplication in medication. So I'm going to give you something like this that is a patient med list. I'll ask you some questions about it, and I think it'll be all stuff that we've talked about, but it will be a little bit of thinking outside the box and really having to remember. I don't do a lot of stuff like this where I require you to remember things from past lectures for exams, but this would be an example where you might see some things come up where you're like, oh yeah, those two things are both antihypertensive agents or both in the same class, or she's on 2 ACE inhibitors or something like that. That's something I would expect at this point in your education to be able to remember. So again, I'm not going to give you much more than that. It'll be a couple questions, and I think it'll be pretty obvious, but again, there might be some stuff on there that's not specific to this module, so I just want to give you a heads up there. I'm not going to ask you clinically to change any of her stuff or to titrate her antidepressants or anything like that if this was the case, but I would want you to be able to know, and I wouldn't ask you about antidepressants on this. I won't go to anything we haven't talked about really, with the exception of maybe putting a benzodiazepine on there to recognize as something potentially inappropriate. So with that being said, just keep that in mind. Again, I think it'll be pretty straightforward, but just so you aren't totally surprised when exam rolls around. Safe prescribing an elderly checklist. This is my personal view on all this. So use as few medications at the lowest dose as possible. Ensure that the medication has an appropriate indication. Double check your drug-drug interactions. Double check doses for adjustment due to pharmacokinetic changes. Evaluate proper duration of therapy. Ensure affordability. Think about adverse effects when a patient reports symptoms. So always think about, especially with an elderly patient on a lot of meds, if they report symptoms, think about the drugs they're taking. Is there anything that might be causing this? Because 30% of patients hospitalized because of adverse drug events. So the odds are, if you have work in urgent care, emergency department, or even in the clinic, and you have somebody reporting some kind of a side effect, it could be very well that it's from a drug. Medication red flags, again, anticholinergics, benzodiazepines, and opioids are the biggest ones to watch out for. Okay, just to finish up this section, to spend the next few slides on dementia. So again, this is an actual disease state that will include testable material, less theoretical, more actual medicine. It's short. There's not a lot of slides because there really aren't a lot of treatments, unfortunately, for dementia. Dementia affects about 4 to 5 million people in the U.S. It's associated with advanced age, of course, 2% prevalence in 65-year-old, up to 30% prevalence in 85-year-olds. So cognitive impairment and memory decline is part of normal aging. Now, how advanced it is and how much you treat it is the tricky part. So mild cognitive impairment is the transitional stage between normal aging and early dementia. And so 5 to 25% of people will progress to dementia. The rest of the people, the majority of the people out there will just experience some mild cognitive impairment as they age. Delirium, mental status change with recent onset and fluctuation, usually related to medical illness or medications, and reversible. So the dementia and delirium, two sides of the same coin. You might see the same symptoms, but very different as to what's causing them and how they're treatable. Delirium should go away once you stop it. Dementia is a progressive, irreversible, not a normal part of aging, but similar in symptoms, just more intense. And symptoms can vary greatly. You can have very mild cases and very severe cases of dementia. Here's some stats on dementia and Alzheimer's disease. So the most common types of dementia, Alzheimer's disease is the most common. Lewy body vascular dementia, I think of, is something that is going to be classified as like post-stroke related memory loss. So I think of that as maybe vascular dementia, and then there's some other types too out there. Goals: maintain cognitive or slow progression of decline, maintain functions of living. Non-pharmacologic therapy would be education, particularly for the caregiver, to know what to expect, to know some of the things to watch out for as far as increases in the decline in memory and how to prepare for those things. Those are probably the most important ones. Reduction in environmental triggers, optimal management of comorbid diseases are all helpful things. And pharmacologic therapy is something we're, of course, going to talk about today. So the theory behind why Alzheimer's disease and dementia happens is because you have an issue with acetylcholine in the central nervous system. So here you have a process where you have acetylcholine being released and getting received by the receiving neuron. You've got your receptors here. You've got your acetylcholinesterase, which breaks down extra acetylcholine, or it gets reuptaked and recycled and reevaluated. Now, what happens in somebody with dementia is that they don't have a process going on here. Or they just don't have enough circulating acetylcholine. The cognitive function is strongly related to cholinergic transactions within the central nervous system. So, for example, one of our common drug classes are acetylcholinesterase inhibitors. So what they would do is actually block this enzyme so you get more circulating acetylcholine in the synapse and your body can use more of it. That's pretty much the major theory behind dementia and the major drug class we're using right now. All right, so a couple different acetylcholinesterase inhibitors. Donepezil or Aricept is the one that's most active centrally. It's the most commonly used one, and it's got very few side effects because it really doesn't have any cholinergic related toxicity or effects outside of the central nervous system, which makes it a very advantageous medication for the elderly because it's not going to cause excessive cholinergic response in other parts of the body. That's a big concern when you're ever giving an acetylcholinesterase inhibitor because you're going to increase acetylcholine, but it really only happens in the central nervous system. Side effects very mild. Dosed 5 to 10 milligrams a day. There's also this 23 milligram high dose. I rarely ever see that used. There's other products too. Rivastigmine is an oral and transdermal patch. The patch is much better tolerated than the oral product. You can see the dosing there. Galantamine is an oral only. Efficacy is pretty similar for all these agents. However, donepezil is much better tolerated. These ones get outside the central nervous system more so, and so you're going to see more GI-related type side effects like SLUD type effects. The other major drug is called memantine or Namenda. Memantine is an NMDA receptor antagonist, so it's a different mechanism. It blocks glutamate transmission, and pathogenesis of Alzheimer's disease may be caused by overstimulation of glutamate receptors. So that's another theory behind why people get memory impairment, and it ultimately leads to neuronal cell death. It's got an immediate release and an extended release formulation. It's well tolerated. It's indicated for moderate to severe Alzheimer's disease and can be used in combination with the acetylcholinesterase inhibitor. There's some theory that actually this mechanism, by starting this early, can maybe be more cognitively beneficial as far as decreasing the progression in illness, but that's theoretical at this point. All right, pharmacotherapy. Mild to moderate Alzheimer's disease, start acetylcholinesterase plus or minus memantine. High study qualities show improved cognition, global assessment, and activities of daily living. Unfortunately, these aren't super clinically meaningful. Yes, statistically they might be better, but as far as the actual impact on the average patient, probably not going to be very substantial. So despite that there being some okay evidence for these, the clinical impact is ultimately leaves a lot to be desired. 10 to 25% patients on acetylcholinesterase inhibitor may show modest improvement, but in most cases they only experience less rapid decline of cognition. There's no evidence for one acetylcholinesterase or another. Duration of therapy usually could be indefinite. You could evaluate it every 3 to 6 months. If prevention of decline is no longer a goal, consider stopping therapy. So if somebody's kind of hit the point where they aren't improving and they aren't, their decline seems to be rapid, or it's reached a point where the drug's not doing anything, you could taper it and try and stop it. Although sometimes tapering it causes more problems than it's worth, so you could keep them on it. But if it's not helping, you eventually probably want to get them off the medication. Dementia-related symptoms, mostly psychosis and agitation. Attempt to address underlying cause, so pain, constipation, hunger, fear, infection. It's not uncommon for these patients to have significant issues that they can't verbalize. So I mean, like urosepsis or something like that is a big risk in elderly patients, because they won't really be able to tell you necessarily that they have urinary pain. That's why in the elderly it's really important, especially somebody who has dementia, to do a full physical workup to make sure you aren't missing anything. Atypical antipsychotics are not FDA approved really, but they're used really commonly. There's not really a standard on when or even if they should be used, but for severe cases of psychosis related to dementia, you'll see antipsychotics used, like olanzapine and risperidone have evidence. However, they also have black box warning saying if you give them to the elderly, you increase all-cause mortality. It's slight. It's not a huge increase, but it was something seen in post-marketing data that they put on as a black box warning. Quetiapine, if Parkinson's disease, like we talked about, or Lewy body dementia, quetiapine, which is Seroquel. Then in here has good evidence. Other treatments, you have antidepressants, very useful in underlying depression or anxiety. SSRIs, or selective serotonin reuptake inhibitors, are first line, minus a drug called paroxetine or Paxil, because that's very anticholinergic. We'll talk about that in the next module here. Start at a low dose to avoid increased agitation. You want to watch out for GI symptoms, possibly hyponatremia, but that's pretty rare with an antidepressant. Most of them are very well tolerated, and again, you're using low doses. Valproic acid and carbamazepine, we'll talk about next week. They're anti-epileptic drugs, and they could be useful for targeting labile or irritable mood, impulsiveness, or combativeness. There's some conflicting evidence over them. They're also, valproic acid, for example, and carbamazepine, they're both actually used and studied they're anti-epileptic drugs first and foremost, but they've been studied extensively in bipolar disorder as well. So think about things that cause, I always think about like bursts of excitatory response in the brain, things like bouts of rage or irritability or impulsivity or aggression. Those can be possibly stabilized a little bit with some of these, and that's why they're referred to sometimes as mood stabilizers. But again, the evidence in this particular patient population is conflicted. You would use fairly low doses if you compared them to like a dose for an epileptic or a bipolar patient. Avoiding benzodiazepines altogether. Some people, benzodiazepines are interesting, and I remember learning this on rotations, is that benzos, in theory, right, they relax people. We talked about diazepam as a muscle relaxant. I think everybody knows Xanax is for anxiety. It seems pretty common knowledge that you can take Xanax or Ativan and you can get sort of a relaxing effect. So theoretically, yeah, if somebody's aggressive or off the wall, give them a benzodiazepine. It actually has the opposite effect a lot of times in people who are delirious or demented. It can make them much more aggressive. It has this paradoxical effect. And so we generally avoid them in these types of patients. Just to talk about delirium really quickly, delirium usually includes two of the following symptoms: misinterpretation, delusions, hallucinations, episodes of incoherent speech, disturbances in sleep-wake cycle, and changes in psychomotor activity. Medication culprits. Oh, what do you know? You got benzos, opioids, and anticholinergics, my three favorite drug classes from the previous set of slides, right? A lot of diseases can cause delirium as well, but I always look at the medication culprits, of course, as being a pharmacist. But for you guys, think about things like ethanol abuse and ethanol withdrawal. If somebody wasn't quite honest with you about how much alcohol they took prior to their surgery, and now they've been in the hospital for 3 days and they haven't had a drink, that's problematic, right? That could easily lead to delirium. So that's why it's really important for patients to be upfront, but also for you to ask those types of questions and make sure you're digging into that appropriately if you're working for a surgical service or something like that, because you're going to be likely the one who does that, not the surgeon. Thyroid dysfunction. Fluctuations in thyroid can make a big difference, and electrolyte disturbances, specifically hyponatremia. So those things are probably the biggest ones to think about as causing delirium. Older adults are at higher risk due to higher sensitivity to medication effects. So think about your older patient who's undergone pretty extensive surgery. They've been on fentanyl and Dilaudid to be put under for their surgery, and now they're in post-op acute pain. And they've been on opioids and maybe even some benzodiazepines. You never really know what's going on. Or maybe they got some diazepam to help with, maybe it was a back surgery to prevent muscle spasms. They give them diazepam a lot for those patients for our neurosurgeries. That can compound pretty quick in an older patient. You can end up with a delirium. You might just have to wait it out until those drugs get out of the system. Good to screen high-risk patients while hospitalized. So people who have some of this background, people who are on a lot of these medications, people who are older or have a history of delirium, those are the cases we really look for. We'll talk about this a little bit more with respect to ICU, because when people are in a medically induced coma, their delirium risk goes up quite a bit, and so that complicates things further. So we'll talk about that again for those of you who are interested in maybe critical care medicine. We'll cover that this summer. Talk about this again, but I just wanted to touch on it briefly, because just remember they're very different. Delirium has a known cause. It's reversible. Dementia, of course, and Alzheimer's disease, very different. But ultimately, the symptoms are very similar. So the way the patient presents will look very alike, just very different causes and very different ways to treat it. All right, that's what I've got for you guys today. Again, not a lot of medications to know for the Alzheimer's disease. I'd really just know donepezil. I'd be able to recognize the other acetylcholinesterase inhibitors, and then memantine as the adjunct or alternative. And of course, you can use memantine and the acetylcholinesterase inhibitors. You can use them together because they're different mechanisms. So a lot of times you'll see patients with dementia on both donepezil and memantine. All right, we'll see you guys next week. Thanks for being flexible with my schedule, and we'll talk anti-epileptic drugs and finish up a couple quick neurotopics.